So now we are going to listen to Dr. Aaron Heffernan. So he will be talking about the ROAD study or the resistant optimized antibiotic dosing in the ICU. Aaron is a clinician scientist working as an ICU registrar at Logan Hospital and currently training with the College of Intensive Care Medicine. He is an honorary research fellow with UQCCR. His PhD and research interests are in individualization of antimicrobial dosing in critically ill patients. Aaron has a Queensland Health Advancing Clinical Research Fellowship to investigate the use of advanced antibiotic dose optimization software to suppress the emergence of resistance and improve clinical outcomes in critically ill patients.
Thank you very much, Hafiz, for the invite to talk about the ROAD study. So, a little bit of background that I don't think anyone in this audience will need reminding of. However, it's clear that antimicrobial resistance over the next 20 to 30 years will be an ever-growing public health concern on a global front as it relates to our patient morbidity and mortality, as well as the significant economic cost associated with increasing antimicrobial resistance, not to mention the flow-on effects as it will relate to other healthcare treatment modalities such as transplant, availability, and success rates. But that brings me to the point about how does antibiotic resistance even occur? Well, it was described first in 1945 by none other than Professor Fleming, whereby it was known that subtherapeutic or subtoxic concentrations of antibiotics allowed the less susceptible bacterial populations to grow and thrive, as well as foster the development of new mutations that allow the selective process of evolution to win and these resistant bacteria to emerge in cultures. However, we also see that in our patients at the bedside as well. When we think about how this relates to our antibiotic exposures, we all know that beta-lactam efficacy relates to the time above the MIC. From a clinical efficacy perspective, we know that 100% time above the MIC has been correlated with improving clinical outcomes both in the critically ill patient population as well as the patients on the ward. However, we also know that these exposures, although correlating with clinical outcomes, may be subtherapeutic as it relates to promoting the emergence of resistance. The concern is that these exposures may actually promote resistance emergence by killing off the susceptible population of bacteria and allowing a subpopulation to thrive and grow, which may be then disseminated across other patient populations. And we know that obviously, as Dr. Mangalore mentioned, that time above MIC or fourfold the MIC has been associated in vitro and in vivo to suppress the resistance of emergence. And so the ROAD pilot study was to first evaluate the safety and feasibility of using a pharmacometrics approach and a TDM approach to individualize the dose to achieve these higher beta-lactam exposures that are associated with the suppression of resistance emergence, to identify whether or not this intervention could actually prevent resistance emergence, as well as look at the important clinical outcomes as they relate to patients such as drug toxicity as well as morbidity and mortality. So this, the ROAD study was conducted as a single site, prospective, unblinded study, whereby patients over the age of 18 and very similar inclusion-exclusion criteria to Dr. Mangalore's study looked to enroll patients admitted to the ICU within 48 hours who were prescribed piperacillin tazobactam or meropenem for treatment of presumed serious infections or sepsis. The empiric doses up to the time of enrollment were described or prescribed by the clinicians treating the patients. Following enrollment, the ID ODS software program was used both to determine the empiric dose as well as to use the published integrated pharmacokinetic models within that computer program to identify what doses would be recommended based on the individual's TDM results as well as their ongoing organ function. Simultaneously, the routine clinical microbiological diagnoses were and diagnostic methods were undertaken, including cultures and MIC determination with the e-test or with the broth microdilution method, depending on the availability of the specific kits and assays. That was then integrated to form the dose optimization or dose recommendation for meropenem or piperacillin, tazobactam. That was then subsequently used to assess whether there was resistance emergence, safety concerns, as well as the clinical efficacy. The dose optimization was conducted by the pharmacists involved in the study in conjunction with the treating clinicians at the bedside. So being a pilot study, obviously very small, only 25 patients, 14 of which received piperacillin, the remaining patients receiving meropenem, all enrolled at the Royal Brisbane Hospital with the obvious corresponding Apache scores and a variety of admission diagnoses to the ICU, most notably in the medical population, sepsis, and then the surgical patients were often post-trauma as their initial admission diagnoses. Importantly, there was the resistance emergence in one patient with the endotracheal aspirate with Pseudomonas. This patient was receiving meropenem and did achieve the target exposure using TDM and the software. The intervention was safe. There were no adverse events directly related to, or that could be directly related to, the drug toxicity. Obviously, being an ICU population, there were quite a large number of patients who did experience adverse events, most notably 3 patients with seizures, for example, but all attributed to alternate diagnoses at the time. 4 patients failed their antimicrobial therapy and 1 patient died, which would not be particularly exciting in this patient population, whereby it's quite common that antibiotics need to be escalated, and in many ways it's almost surprising that only 1 patient died in this particular patient cohort. From a intervention efficacy outcome perspective, the target, which was set at 4 times the MIC as the trough exposure, was met by most patients, and most patients met this target within 1 day of enrollment. There were only those 2 patients who didn't meet the target exposure despite having increasing doses and reducing dosing frequency. However, they also only received the intervention and the antibiotics for 3 days, meaning that it was unlikely that they were able to have a sufficient exposure of stable organ function to meet the required targets. As you would expect, most patients needed a dose increase. The doses used were typically up to 27 grams a day of the piperacillin tazobactam, as well as normally up to 8 grams per day of meropenem, so higher than the usual prescribed doses for most patients within the ICU population, or at least that described by the product information. And obviously, this study being conducted at the Royal Brisbane and Women's Hospital, many patients were changed to a continuous infusion within the first 24 hours of the intervention commencing in the ICU. We can see that as the number of days of therapeutic drug monitoring occurred, that patients, or the percentage of patients, were increasingly within the therapeutic range. I would note that no patients were deemed to have a high exposure. Once again, a high exposure was correlated or was very similar to the exposures described by Dr. Mangle, with the piperacillin trough exposure of greater than 160 milligrams per liter and greater than 20 milligrams per liter of greater than 40 milligrams per liter of meropenem. Patients within the first day or two of TDM had low or subtherapeutic exposures, defined as less than fourfold that MIC at the trough. And of course, there were some elements of missing data on the corresponding days of therapeutic drug monitoring, typically correlating with weekends where the service had limited availability. The take-home points from this pilot study is that, similar to what Dr. Mangala described, is that this is feasible. Obviously, being in a center that's more accustomed to performing TDM and integrating therapeutic drug monitoring into their natural workflow in the ICU, it's very easy to say in many ways that it is feasible, but we've already heard from other sites that this is something that can be done on a wider scale. It's safe. The dosing intervention to achieve these exposures does not seem, in this small cohort, to increase the risk of adverse events, given that the intervention of the dosing change and the exposure are actually monitored as opposed to standard of care where a single dose is used. And we've already heard that the single dosing regimens do have a wide variety of exposures whereby you would look to change the dose in many patients, and that this is a likely effective method to suppress the emergence of resistance and potentially improve clinical outcomes for these critically ill patients. So that takes us to the ROAD RCT, of which we are developing the protocol for now. The current clinical implications of this are fairly subdued given the pilot nature of this study, but it does add to the growing evidence base that it is the exposure, in many instances, aside from those more paradoxical and idiosyncratic drug adverse reactions, that correlates with the likely adverse events and not necessarily just an increased dose itself, and that this may represent an easy, on a relative scale, intervention to reduce the risk of resistance emergence in our patients that can stem the tide of the growing risk that we face on a global level. This study's already been published in CMI Communications. So thank you very much to everyone involved in the study, of which there are many, many people, particularly the pharmacy department at the Royal Brisbane and Women's Hospital, and obviously with the CRE Reduce for their ongoing support of this particular project. So thank you, everyone.
Thank you, Aaron.